All right, and this can be edited, so this part is going to be edited out. But right now, you may begin. Just double check because I'm make sure it works. Looks like it's working. That's
okay.
Good. There we go.
Sit. Oh, I'll just stand. Yeah.
Okay. Good afternoon. My name is Karthik.
I'm Malvika.
So we want to present about a design challenge that we participated in the summer of 2018. And briefly, so we wanted to kind of highlight about, firstly, about social isolation in older adults in the United States. There's enough evidence to suggest that social isolation is a significant risk factor for poor health status, and there's an increased all-cause morbidity and mortality across. And evidence also suggests that individuals with adequate social relationship have about 50% greater likelihood of survival. And there's a substantial burden of social isolation to the US healthcare system with increased emergency visits, delayed discharges. But then the economic burden is equally well documented, with an estimated burden of about 6.7 billion annual federal spending across the entire country. While we recognize the problem of social isolation, we understand the present challenges in capturing data regarding social isolation. The electronic health records normally don't capture this individual level social isolation data, primarily because of difficulties in data harmonization across all levels, and also because the clinical workflow is not really well integrated, and therefore displaying this data to healthcare professionals is very challenging. But then the other problem from the patient side is for typically the socially isolated older adults, it's difficult to capture the usual, identify the usual source of care and the usual source of data regarding social isolation for each elderly patient. And also there are cultural and language challenges. And then with the fear of clinical setting and technology adoption being a huge barrier for older adults, there have been huge difficulties in capturing this individual level social isolation data for the elderly population. So we've realized that one of the best solutions for this would be capturing data at the patient level. So we've focused more on using the patient-generated data, capturing it at the patient level. So we've had a three-pronged solution. The first one being having a patient-facing app that would capture all this data regarding social isolation at the patient level. And then there is, at the federal level, we have evidence from the Institute of Medicine, which kind of recommended capturing data related to the frequency of contact, frequency of interaction with family caregivers, and also marital status, especially at an older adult, because that would have a huge implication on their well-being. So there is enough evidence now, and there are recommendations even at the federal level that this data needs to be captured, but then the EHR today does not capture this information. So we therefore felt that capturing this data from the patient side through a patient-generated data using a patient-facing app as a first part, and then pushing this data into the EHR, integrating this information into the EHR. And the third part would be providing this visualization to the clinicians for clinical decision making. So therefore, we had these three-pronged decision, and then we collaborated with the Center for Aging and also the Orange County EMS, which kind of helped us in the design process.
So we want to really emphasize that we used a user co-design process to really understand the problem and how we could address the problem with our interfaces and intervention. So the patient and health professional facing interfaces were developed, and then we went through iterations with the patients and then the health professionals respectively. So first we created user personas of a patient and health professional to describe socio-demographic characteristics and how users might interact with the platform. And then we conducted interviews with the patients and health professionals so they could provide feedback and also propose useful components of the system. Some of the most useful feedback we received was that the geriatric health professionals were interested in the use of validated and standardized patient-reported outcomes. And they wanted them to be specifically related to social isolation and quality of life. And then the older adult patients provided insights into important accessibility features, such as the use of a TV medium for information, multiple modalities of data entry, which we'll talk about later in the form of text and speech and their interactions, and then minimizing the number of clicks to complete tasks. So low fidelity prototypes were first sketched on paper, and then we went through iterations within the research team. And then the high fidelity prototypes were created using Adobe XD. And then the patient and health professionals would provide feedback on them. For older adults who may be unfamiliar with technology or have physical or cognitive impairments, we really wanted to focus on ease of use features, clear error messages, and error forgiveness. And both interfaces were informed by the design requirements identified by the clinical decision experts and the guidelines for interactive visualizations identified by Hiran Schneiderman, yes, and feature recommendations for clinical decision support systems. Now going into the patient interface, the components of our platform were based on components from a systematic review that we conducted of TV interventions for socially isolated older adults. Now, this drove the inclusion of group therapy sessions, individual video communication, and access to expanding social circles, as well as health-related information and activities and the PROs. So the PRO questionnaires are from the Patient-Reported Outcomes Measurement Information System, as we know, PROMIS, so short form social isolation, and the Euro QOL 5 dimensions, 5 levels of quality of life. Now, the patient interface was created using the social network theory as a backbone to kind of inform exactly how we would incorporate all these levels of interactions. And so we wanted to take into consideration the network structure, environment, and dynamics between the interdisciplinary care team and the patients, as well as their existing support structures, if they had any. So now this shows essentially from the outer ring, you have the interdisciplinary care team, which could consist of the community paramedic, which would so the community paramedic first sees the patient, identifies the patient. And then the care team could consist of a dietitian, social worker, and primary care providers. Now in the ring here, we have the social circle. Now that's what we use to describe the patient's existing support structure. That consists of family and friends of the patient before they come into the program. Then we have the patient in the center. And here we have all of the relationships that the patient would make through the platform, interacting with people through the group therapy sessions, clubs, activities, and so on. So we'd first like to dive into just kind of screenshots of the interface, and then after discussing the components of it, we'd like to show you a video about how the patient would interact with it. So first, we have a colorblind palette and high contrast text for readability. Now that I'm looking at it, the white may not be the best decision, but the black was definitely for readability. And then here we have the search bar, which, which can be used to navigate the components of the app. And then in settings, the community paramedic would create a user profile for the patient, like with the patient right there. We don't have that, page in the interface right now because we wanted to work with a community paramedic in order to develop that much later on. And now this giant banner right here, the join session, that's for the bi-weekly group therapy sessions, which are based on the evidence-based guidelines from the American Psychological Association. And so these would be on various topics, health-related topics. So for example, in nutrition, a dietitian could lead this discussion. and have the people in the program kind of interact with each other, ask questions, but still be able to understand useful information for their daily lives. And other things that we found would be useful after interacting with geriatricians and other people from other healthcare professionals would be, for example, grief therapy for individuals who may not have their spouse with them at the moment. So next, one of our challenges was that these PRO questionnaires are meant to be on paper, and they're designed on paper. So on the left here, this is the social isolation short form from PROMIS, how it's originally designed. And on the right, we have the version of the form that we transformed for use with the Fire TV. And the patient would be able to interact with this either by clicking or through Alexa Voice. And this is the quality of life questionnaire on paper, and this was actually very difficult. We grappled with how to take this long form and apply it to a TV medium in a way that we'd still maintain ease of use. And so what we decided to do was to separate it out by these bolded headings. So instead of one form, it would be 5 components. And so each of these is a screen. And so the patient would interact with this either by clicking on a box or saying like select one into the Alexa microphone. And then hit next, and then go on and do self-care, then usual activities, and so on. So then I kind of want to walk through the tabs also. So first we're going to talk about the contacts tab and then the activities tab. So the contacts page would be used to connect patients to their program friends, social circle, and care team. And the first row right here, the recents, these are automatically updated to contain individuals who the patient last connected with. And then program friends would be defined as friends through the social living platform. And social circle, like I described earlier, would be family and friends before the platform. And in the care team, there could be the geriatrician, social worker, and primary care team. Now, all of these would be connected with our video interface. And so if you clicked on one, you would kind of open up like a FaceTime almost. Now, the activities tab, from our systematic review, we gathered that conveying health-related information, having activities, and facilitating participation in social or community organizations could contribute to tackling social isolation. So we wanted to include educational videos first, and then games where the patient could interact with other people on the platform and play games with them. And then clubs that the individuals could either create after meeting people, or if there were some clubs that they kind of decided in the beginning, could have them as defaults. And these club meetings would happen in the same way that you would have video conference for the group therapy sessions. And then local activities would be based on the patient's home location. So these would be automatically populated. So we have the library right here, but it could also include churches in the area or other spiritual activities. Yeah. Okay, so now integration with EHR is super important. It's also the second bullet that we talked about earlier. UNC Healthcare uses the Epic EHR system, which allows for the use of third-party developers to develop functionalities within the EHR. So we wanted to take advantage of that. And the social living platform would utilize the HIPAA-compliant Microsoft Azure cloud infrastructure through the UNC School of Medicine, which addresses the issues related to limited FHIR capabilities for PROs that are incompatible. And additional security measures specifically for UNC, like a Duolingo security requirement, and full audit trails would have to be maintained. And for the web integration API, we made sure that all of these measures met the industry standard for transport layer security. Okay, so now we want to show you the video before going into the health professional interface. Make it big. This is just a 2-minute video walking through how a patient would interact with this. So the black would be the patient speaking, and then the blue is Alexa. And this is the group therapy session. And so it would directly feed into the group therapy session from the questionnaires to ensure that the patients would actually fulfill the questionnaire before going into the session. And this is an example of how the patient could interact with someone else from the program and have that FaceTime sort of call with them. Okay, I think that's it. Cool. How do we go back to the...
Now, on to the health professional interface. What we wanted to do is understand first, improve upon the social documentation tab that's present in the EHR, and then also provide more of interactive dashboards so that you can visualize, so you can help the health professional visualize this information more effectively, and provide information regarding weekly and monthly social isolation scores and the quality of life scores that the patient has really filled up from their end. And then one of the integral features that we had were a lot of built-in alerts. So each time the patient's scores of social isolation or depression fell below, there were alerts that were sent into the healthcare professional. So this is the present interface of classically any EPIC or any HR, except for the fact that we had the social living app icon placed in the social documentation. So presently, this is like it's an empty box wherein information is typed. And what we hope to do was provide this icon in the social documentation. And then when they click upon this, they would have an introduction to the social living platform. And then we have a tutorial here that would help providers understand the features of this app, primarily to improve their learnability. And then once they learn, they can quickly skip so that it does not appear in the next the next time they interact with the interface. What we also had was, so this interface, if you see on the top left, this is clearly the demographic information that most clinical experts would want this. And then we have the updated raw scores. And then what we tried to do was we had two different colors, largely focusing on human perception, the fact that colors that are brighter, that would be more, that are distinctly available for them. And then we kind of have this section that would kind of help them at a very high level understand the categories of interactions that these people, that this specific patient would have. So here you would see the number of group sessions that they've attended. And this is all data that would come from the patient-facing app. And it is so there are group sessions attended, the individual participated activities, the programmatic friends that they've developed, and interactions with the social circle. So at a very high level, there would be information regarding the categories of interactions that they've had. And then this tab, the primary contact tab, this is one of those informations that clinical decision experts constantly ask for, and this is information that's really not available on EHR, and this is something that we got from more of systematic reviews. And then the bottommost tab is necessarily the documentation related to the social learning platform, the API that's required. And here, on the topmost part, what we have is information, the timely information regarding what is the next therapy session that the patient has, and what is the other timely information of the patient. But then at an overall overview, this is an overview information that we provide using stack bars and line charts, and it provides some general information about the total interaction that they've had. And then the quality of life and the social isolation is available as line charts. And the next interface, this interface also has the promise social isolation. This is the four item questionnaire regarding social isolation, which is available for the healthcare professional to understand what are really the questions in promise. Similarly, in the quality of life, they can click on those buttons. They would come up as pop-ups so that they understand what really are the questionnaires that the patient has filled. So not only do they get the scores of each individual patient for the social isolation and quality of life, but they also know what is the questionnaire, what is the evidence behind them. So this is available as a quick pop-up for the healthcare professionals.
So now we want to show a video similar to the patient-facing one, but for healthcare professionals navigating through this interface. I think she takes a second for each thing, like sits on it.
So they could click on this so that the questionnaire pops up. And with this, the quality of life questionnaire. Now, what we wanted to highlight on this was the dynamic widget. So the moment they move to, so we have this this is a stack bar which kind of shows. So for January, we had the high level number of interactions, but then when you dig it deeper, you would be able to get the different types of interaction that constituted January. And then for different months, you'd be able to show the nature of interactions and also show the scores of both quality of life and social isolation. So we've till now shown a combined score of both social isolation and quality of life. Now this is just social isolation scores for each month. And this is social isolation for the week.
And so on the left, you'll see the number of interactions. On the right, you'll see the raw score. Yeah, I think it's done. Yep.
Yeah. So while moving towards a social living, developing a social living platform on a television-based as a television-based platform, we also considered what could be other potential solutions. So the most standard one would be mobile and tablet-based apps. But then the reason why we did not go for a mobile or a tablet was largely considering the dexterity issues that elderly would have, and also the fact that in terms of the flexibility, in terms of their ability to interact with a surface that would not help them move around. So we felt that a mobile and a tablet-based app may not have, and it also does not have the ability to use voice recognition as well, some of them. And so, the most important reason why we chose a TV-based platform was the fact that elderly people spend about 3.3 hours per day on a television. And so we felt it's a great platform to utilize. And then the specific reason why we chose Amazon over Apple was a fact that Amazon was more cheaper. It had a greater market share, so we felt there could be more people who would use it. And then the accuracy of Alexa over Siri. And then the video chat features that were available on Amazon TV, which Apple didn't have. So for these reasons, we've kind of preferred Amazon over Apple. But then we also recognize that there are large number of patient barriers and healthcare professional barriers, even within this as well. And the fact that elderly people, despite the fact that you provide them voice recognition features, there would still be a lot of barriers, and we recognize this as well. And so what we wanted to do was, after doing a usability evaluation, we wanted to think about how would we want to implement and disseminate this. So we wanted to build the implementation of this platform, of this product on an existing community paramedicine program that already exists. So right now, what would happen is, I'm sorry, it's too small, but what would happen now is when an elderly person typically calls the 911, and they accept the transportation to the hospital, then they get the care that is needed, that they need from the ED. But there are a large number of them who do not accept being transported to the hospital, and it is these people who are placed in touch with the community paramedic, and therefore the community paramedic builds a lot of trust for these people. And then if they are willing to enroll themselves, and hopefully we'll be able to provide the entire social living platform as an entire package to such people. We'll be able to enroll those people and then train those people and ensure that this package all the training that is needed for them would be provided by the community paramedic. And then we have data usage agreements between UNC and the Orange County EMS as well. And so we wanted to build upon that. So what we hope to do was, provide from this solution is that we could use new communication modalities, and using a social living platform or a TV-based platform is possibly not extremely innovative. In fact, there are countries like Finland which have been using a TV-based platform for so many years. So there's a lot of evidence that that TV-based platforms can be extremely useful for older population. And so we kind of built upon that, but we don't have a lot of other examples wherein you use patient-generated data from the patient using a television-based platform and then integrated with EHR. So I think to that extent, our solution was, our design features and our solution was innovative. And then we felt this should hopefully address some of the significant gaps and barriers. And then we hope that we not only unite the patient with the social circle, but also expand the community. So this was our attempt, and this was as a part of a student design challenge by the American Medical Informatics Association that we participated over the summers. So that's it. Thank you.
Have you thought of expanding it? Because I was wondering about, my mother loves her Kindle, which is has the Alexa app and all of that. Have you thought of expanding it to maybe a tablet like that uses that Amazon platform?
Yeah, but the problem in some of them is they wouldn't have all the 3 features that are needed. You need voice recognition. You would want them to, the fact that in a television, they'd be using the remote. So there could be older adults who would not have their ability to use in a tablet is far more, there could be more challenges that they have compared to using a remote. Remote is something which most people use. And when they don't know how to use a remote, they could use voice. So you're providing additional facilities through a television-based platform, I guess.
I'm also not familiar with newer versions of the Kindle and how that would, the video calling and those group therapy sessions are kind of integral to the program. So how that would work over Kindle, I'm not familiar with.
It's basically like an iPad or an iPad video.
Right.
Okay.
Yeah, that's really interesting. What was the tool that you used to do the prototyping?
Adobe XD.
Adobe what?
Adobe XD.
XD, okay.
It's pretty cool.
Yeah.
And what is the business model for this? So somebody comes and they could talk to the community paramedic and said, yeah, this sounds good. I don't have an Alexa TV at home. Someone would supply it for them?
Yeah.
So I think there's an existing community paramedicine program. So so in that, what would happen is, I think you would have liked it to be a little more larger. So when they come up for a follow-up call to the community paramedic, this is a person who's not accepted being transferred to the hospital. So when he comes to that, the community paramedic builds in a certain amount of confidence and trust with that particular elderly person. And then he does a phone call screening for enrollment to this program. And when he realizes, okay, there are these certain requirements that you have to be a part of this program. When he fulfills that, that's when the program would get, that's when he would get enrolled into the program.
Where does the money come from to do that, to support the entire program, including the hardware that goes to somebody's home?
So we kind of did the economics of that, and we felt this would be something that would, there is an existing cost which is already there as a part of the community paramedicine program. So they would take up a part of the cost, and the other one would be both from the UNC Center of Aging and the EMS, because they're kind of collaborating with us.
And for all of the hardware, system requirements, and features, we quoted about $200 per patient as our estimate.
I really like the idea of the TV-based platform. I'm just imagining what you have to do to try to get somebody to like participate in something, and I can imagine a lot of people are already sitting in front of their TVs. So that seems like it would be a helpful one. Even actually a pretty simplified remote might still be a barrier for some people.
Yeah.
But presumably you can get around that, especially if you get a home visit or something like that to help somebody.
Yeah, so one of the things, so I have a Fire TV, like my TV has the built-in Fire TV, so my TV remote is the Fire remote. It's incredibly annoying, like to try and click through. And so I actually try and use voice a lot of the time as well. And it does work fairly well. So I feel like that was one of the things that we noticed. If it was annoying for us, then imagine how annoying it could be for other people. Yeah. And also just some, I guess, context. When we decided to choose Amazon over Apple, this was also before the group FaceTime was implemented.
Right.
So that was another pretty big thing that we were looking at. How can we facilitate these like large scale video calls?
Yeah, I think another problem with that would happen if you try to have the social element of it, is there'd have to be enough people to support that. So if you have millions of people, then there's always somebody who's ready to talk. But if it's limited to Orange County and there aren't that many people signed up yet, especially to begin with, and if there's nobody to talk to, then it's hard to jump into it. But the other features of the app could carry it to that available or something.
Right. So the first author on this, Rachel Stemmerman, she's actually a paramedic in Orange County. And so she was already familiar with the program, the community paramedic program, and understood that. So this came from like a need that she saw after working with community paramedics, and that there was a significant population that could benefit from something like this.
I have a couple questions.
Please.
I thought it was really neat. So this is if we're assuming that this is for an aging population, correct? So we're assuming that they use Alexa regularly. I was wondering in your research, did that come up? Did you see how many aging people use Alexa regularly and how much most it would be for them to kind of
So the evidence is definitely that Alexa is more accurate than Siri. But then in terms of saying how many elderly use Alexa, or I don't think there are.
I just wondering if there was.
Right.
I mean, at Blue Cross we do a lot with calculating indices for social isolation, so it's definitely a very needed product. In terms of so it would require an Alexa and a smart TV to do this. So like, I guess have you thought about maybe targeting like senior centers or assisted living facilities that would, be able to incorporate that into their living as a package of just a thought?
So that's definitely a really good idea, but so our population was slightly different in that.
I'm sorry, I missed like the beginning.
Oh no. No, just some context is some of these people just don't leave their homes. Right. So we really wanted to focus on kind of developing a community for people who would not get out into the community. Yeah.
And contrary to popular belief, it's actually that 60% of older adults actually live at homes and not really at assisted livings or senior homes. So I think this is precisely to kind of help those people who live, at homes.
I was just thinking from like a user rate setting, like it's kind of contrary to the problem you're trying to solve.
Right.
And then I was just wondering about the questionnaires. So I saw that the graphs were monthly. So is it a once a month questionnaire that you do?
No, so it would be they would be bi-weekly along with the group therapy sessions. Okay. So when the user would click this join session button, it would immediately go into the questionnaire. So before interacting with other people, you would actually have to. It's almost like an entrance requirement. Yeah.
And so I guess it would have reminders every time someone needed to take it.
Well, so the reminder would be to have your session.
To have a session.
To like you have this group therapy session at 7 p.m. Or so 6 p.m. Yeah. And so then an alert would come up for this, and the PROs would just be part of the session.
And then after you take the questionnaire.
First, you take the questionnaire first.
And so the sessions are bi-weekly? Also?
How are they assigned sessions or assigned groups? How are those sessions done? And is there any kind of alert if they don't attend a session? If they happen to maybe miss one, that there's somebody to maybe check up on them?
So each time they get a low score or social isolation or quality of life, there are alerts that go to the care team. So depending upon whether it's a primary care or the geriatrician or the community paramedic, the paramedic would either call him or even visit homes. So that's one. And second is there's also interaction regularly with the care team. So the interaction with the care team, the interaction with the social circle, which is friends and family, and then the programmatic friends that they have. So with whom they're either playing games or they're participating in different sessions, all of these get calculated. All of these is also estimated through the app. So you're getting this information directly as well. And so you also have those alerts that build in that kind of give you those information about who is doing well, who's not doing well.
And I was thinking about the social isolation versus social connectedness. I was trying to figure out, is a high score good or is a low score good? And then I was thinking, maybe you could use social connectedness and then it's like high is
Right.
good.
Yeah, but I guess, yeah. Oh, okay. You're talking about the graphs?
But yeah, the
Yeah.
graphs and the scores.
Yeah, if you go to, wait, where's the,
If
Yeah,
score
there we
5
go.
to 15, 25, do I want a 5 or do I want a 25?
right, so you don't want, so the always would be a pretty bad thing.
Okay.
Yeah. So you
So this
want,
is a social isolation score form. So this is a short form 4A. So there are multiple types in PROMIS. PROMIS is the most commonly used patient-generated data forms.
Right.
So for social isolation, they have a 4A, they have an 8A, they have a 12A.
Mhm.
So this is the shortest form that we had.
right, so like it is a little bit counterintuitive in
Yes.
that you would think that like,
Mhm.
oh, a 5 would be great, but no, a 1 is what you want.
Yeah, it's
Yeah.
like
Yeah.
it's like isolation golf, you know, like a low score.
Yeah.
Ain't getting lower than a hole in one.
Yeah.
So I was thinking about when the physician sees this and they say they look and they go in the EHR and they say like, oh, this person's score is lower than I would like to see or worse than I would like to see. What actions would you then have follow up? Would you suggest maybe reach out to this person or what would be next?
Yeah. So what was hoped to do? What we hope to do was more than the physician. We know that the community paramedic is the one who has a more greater interface with them because he's the one who's conducting a lot of sessions. So they would either do a call-in, a telephone call with the person, and then if we see that the scores are even more lower, maybe do a home visit as well, because they are the ones who are living closer to the community. So it's not that the physician really needs to come in. So even before the physician sees it, we hope that either through the community paramedic and then the geriatric social worker, they would be the first two levels before they actually go to the physician. Right now, what happens is these two levels, they really don't have any information. So it directly goes to the ED. So what we're hoping to do is reduce the visits to the ED, and it is the first two levels who really know what's the extent of interaction, and then the countermeasures could start.
So, I was just gonna say, so you plan on using the paramedic community first before connecting it to physicians? Is that what you're saying?
Hopefully.
Yeah, so it would start out from this outer level and then get connected to the care team. And then closer to the patient, of course, is their family and friends currently. I think patient.
Yeah, I guess the barrier there with physicians is just that depending on the health system, and it can be a struggle to get EHR, even if it's an EHR enabled, not always EHR, they don't always allow, like for example, UNC maybe is a yes, but Duke is not.
Right.
Or like,
Yeah.
like just because of privacy issues, it's that we have a standstill on integrating apps, right? And so that's
Right.
always very, but I guess if it doesn't require the physician, then you can always still at least have the first level.
Right.
Yeah, and so we actually only looked at requirements for integrating into the UNC EHR. So
I guess
in the
you are working
future,
with
future
UNC,
consideration.
right?
Yes.
Yeah.
Yes.
So
Yes.
that makes
Yeah.
sense.
Yeah.
And then there's sort of like true integration into the EHR where the data is passing back and forth, and then there's
Right.
one that's just like a link with an interface that you can get out to pretty quickly.
Mhm.
So there are ways of connecting even without really connecting, I suppose.
Right.
And then, yeah, it seems like with an ACO model, you know, with the value-based care, you could find somebody who is, is incentivized to keep people on PED.
Yep.
And so, what is the next steps? Are you going to launch it?
So yeah, we're not sure. Because one of the things that when we presented this, we presented a poster at AMIA in the fall, and some of the feedback we got was that it would be really interesting, and there are other programs, I believe, like someone from Yale was working on the same population and something similar, but not a TV-based intervention. But we kind of decided, we were like, should we or should we not? Because none of us are really actually focused on this for our dissertations. So it's more like a time thing.
Yeah. It was a summer project, I would say.
Yeah, but yeah, every time we talk about it, it's like, oh, this would be really cool. We should do this. We should actually build it out, but then we haven't. Yeah, that's it.
The paramedic you're working on fishing out water?
Well, so Rachel's working on extracting social determinants of health from the EHR. That's like her dissertation topic. And yeah, so she just saw this because she's still working as a paramedic, and so this is something that she sees regularly, like as a recurring problem. But yeah, that's
I would
just.
just think she'd want you to watch it.
Well, yeah. So yeah. So some of the things that we would need to do is actually build it, because right now we're still in the prototype phase. And so building the Fire TV app, and then building out the health professional interface. And making all of that compatible. I think it would definitely take like at least a year to at least a year to do.
Have you gotten any feedback from UNC for that this is something they might be interested in working on or helping with?
Yeah, I think the interaction was largely with the UNC Center for Aging. I think we've had multiple discussions with them, but I think for us, we did not anticipate that this would be. For us, it was more about learning and using. So it was more about taking this challenge, and we had more of public health, and she was more of machine learning. And so for her, it was a side project. So we kind of dived into it just to kind of learn and see what is it that we can come up with. It's only much later we realized, okay, there's a potential. But then we've all gone into different, so most of our dissertations are different. So we've kind of let it be. So, but then we kind of very happy to share about this. So wherever we get opportunities to talk about this work, we do take it, and we hear good feedback from them. But we've really not had the next set of, ownership. Somebody could take ownership of this and build upon.
Yeah.
This is sort of thing. It seems like there are so many things that don't happen or do happen and fail, and that's okay. It's part of the process, I think, of sharing these ideas. That
right.
Sort of somebody borrows some ideas from this and create the next app that makes a difference. That'd be great.
Yeah.
No, yeah, for sure. And I mean, so there's one more person on our team, Ashley Griffin, who's working with conversational agents. And so she was also super excited about this, but it's also not her subject area as well. Yes.
Thanks, everyone.
Thank you. Thank you for having us.
That's cool.
Hi.